The presentations are actually quite varied, with visual loss being fairly common, but it's peripheral field visual loss, so it can be quite difficult for patients to detect until it becomes quite advanced. And then there are the imbalances of hormones resulting in symptoms either of deficiency or excess, and a group of patients who are found to have a pituitary tumour incidentally on MRI scanning for other reasons. And then the investigation of these symptoms is two-sided. It's the endocrine blood tests to check on pituitary function, either deficiency or excess, and then MRI scanning, with the addition of ophthalmology assessments if that's appropriate. The first question is which type of pituitary tumour is presenting, and that is categorized as either functioning or non-functioning to start with. So the non-functioning adenomas are treated surgically if that is required, and the decision for that depends upon the size of the tumour, whether it's threatening or causing visual deterioration or compression of other brain structures, and the other type being the functioning adenomas that are secreting hormones, which would be prolactin or growth hormone causing acromegaly, or ACTH causing Cushing's disease, and rarely TSHomas. Of these, the prolactinomas can largely be treated medically, and as long as there are not substantial side effects, that's usually a very effective management. Whereas the growth hormone and ACTH secreting tumours require surgical resection, and the decision beyond that is whether surgery is successful in achieving remission and whether any adjunctive treatments are required, additional medical therapy or radiotherapy. So the hormones produced by the pituitary gland can either be reduced by the compression of an adenoma, and that is the more frequent type of problem, or they can be excessive due to production from the tumour. So deficiency will most often cause rather general symptoms of lethargy, energy loss, muscle weakness, and then problems with loss of periods in women, impotence in men, and infertility are quite common presentations. But the overall is the loss of a sense of well-being and energy. The functioning adenomas producing growth hormone or ACTH have very specific syndromes associated with them. So growth hormone causes acromegaly with a change of facial appearance, expansion of hand and shoe size, and foot size, and sweating being the main symptoms. Cushing's disease causes weight gain, change of body habitus, facial flushing, hypertension, and quite a number of other body changes, including things like osteoporosis. So they're difficult to diagnose because they occur so slowly and gradually, and can mimic the aging process, but they then gradually step outside the expected rate of change and require quite advanced endocrine assessments to be certain of the diagnosis. The usual practice currently is to perform endoscopic transsphenoidal surgery for the vast majority of pituitary tumours. Those that are particularly large or extend up into the brain further than the run-of-the-mill type of tumour may require what's called an extended transsphenoidal procedure, and that is to open up more of the skull base to access the center of the skull and the brain. The other option of performing a craniotomy, so an opening in the side of the skull, is rarely required now, and only in very, very large tumours and inaccessible places that they have extended to. So that's very unusual to require a craniotomy nowadays. So those are benign tumours. They do have a recurrence rate, and the chance of that depends on how effective the tumour removal has been and what the post-operative scans show, whether there's any mass evident on MRI. But all of them, even if there's a very good clearance, will require long-term MRI monitoring to make sure that there's not any recurrence. And this will need to continue for approximately 20 years after the surgery on a gradually reducing frequency basis. There may be a need for ophthalmological follow-up if there is significant impairment and wanting to keep a watch on the optic nerve function. And of course, endocrine follow-up is very important, not only to assess the pituitary function as it is post-operatively, but if there are any potential changes over time, such as with regrowth of tumour could cause further endocrine deficiency, or if there's a need to give radiotherapy when the pituitary can gradually fade out. So there will be a requirement for long-term monitoring with both imaging and endocrinology.